Hi, my name is Aditya Bagrodia, and I'm a urologic oncologist at UC San Diego Health. Today, I'm going to talk a little bit about testicular cancer and walk us through the whole journey from diagnosis and management. If you or a loved one have recently been diagnosed with testicular cancer, understandably, there's a lot of anxiety and consternation that comes along with a testicular cancer diagnosis or any cancer diagnosis. But I hope after this video, you'll understand that this is the most highly curable solid cancer that exists. Our jobs are to cure you of your cancer and make sure that you don't have to deal with any side effects of the cancer for the remainder of your life. So, after watching this video, the goal is that you'll understand the process from diagnosis to management and be able to advocate for yourself so that everything is done just perfectly, ideally at a center with experience and expertise in managing testicular cancer. So, a little bit of a background. Testicular cancer is the most common cancer in men between the ages of 18 and 45. In the United States, there's about 10,000 cases every year. Some of the risk factors are a family history of testicular cancer, a personal history of testicular cancer, an undescended testicle as a child, and there's some other less common risk factors. While we can cure the bulk of patients with testicular cancer, even when it's spread. Nevertheless, about 500 patients do die in the United States every year of testicular cancer. And because of these excellent cure rates, again, it's absolutely mandatory that we do everything perfectly so we can cure you or your loved one and make sure they don't have to deal with any side effects. Typically, testicular cancer presents initially as a painless mass or lump in the testicle. And if you palpate such a lump, it doesn't necessarily mean you have testicular cancer. There can be other um, signs and symptoms of hernias, fluid in the testicle that mimic a testicular cancer. But at that point, you should generally see your primary care doctor. Sometimes patients go to the emergency department. And the first tests that are typically done are a scrotal ultrasound and some blood work. And the blood work specifically is looking for a couple of things in the blood called tumor markers. And the three tumor markers that we generally look at are AFP, beta HCG, and then one that's a little bit less specific called LDH. And between a combination of a physical exam, the history, the ultrasound, and the tumor markers, we can generally say with about 95% accuracy whether or not you're likely to have testicular cancer. At that point, generally you'll see a urologist, and the next step in the diagnosis and management is to perform a procedure called an orchiectomy or removal of the testicle. It's generally about a 30 to 45-minute procedure. You can go home the same day. Typically, Tylenol and ibuprofen are perfectly sufficient for pain control purposes. Your urologist should talk to you about placing a testicular prosthetic at the time of the surgery, should you want. So that's a saline filled implant that could occupy the space of the removed testicle. And then they should also discuss fertility preservation, sperm banking, ideally before the removal of the testicle. After the removal of the testicle, many times it's been a really fast moving train with a primary care doctor visit, ultrasound, blood work, urology, and surgery, which we try to do pretty efficiently once we are concerned about a diagnosis. And then there's this period of waiting that can be a real source of anxiety and consternation for the patients. That's completely normal. A lot of times after the removal of the testicle, we're going to try to get CT scans of the chest, abdomen, and pelvis, along with a repeat set of tumor marker blood work. And that's going to give us the stage of the cancer. And what the stage mean is we're trying to understand where all cancer cells may be located, if there's any evidence of spread. And that is really critical in dictating next steps, along with what's seen under the microscope when the pathologist examines the testicular uh, specimen that was removed. So, staging of testicular cancer, in some ways, it's kind of straightforward. So, again, there's no stage 4 testicular cancer. We can cure this across disease states. So, the testicles actually begin at the level of the kidneys and then descend into the scrotum kind of shortly before we're born. This all takes place in utero. And if the cancer cells are confined to the testicle, we call that stage 1. If they've spread somewhere along that path of descent into the retroperitoneum, where testicular cancer tends to spread in about 90% of cases as the first spot, we call that stage 2. And if there's cancer cells that have gone other parts of the body, like the lungs, the liver, or the brain, then we call that stage 3. And these stage implications have a real impact along again with the histology on what comes next. So when you meet with the urologist or your care team or a medical oncologist after the orchiectomy, the three critical pieces of information are, was this a seminoma or a non-seminoma? And those are the two broad categories of testicular cancer. What do the CT scans show? Are they clear, or are there evidence of cancer cells that have spread or metastasized into the retroperitoneum, making it stage 2, or outside of the retroperitoneum, making it stage 3? And then what do the repeat serum tumor markers blood work show? So starting out with stage 1, generally speaking, the survival, the likelihood of you being alive and not dead of testicular cancer, and also cured of testicular cancer in 5 years is about 99%. So again, if you're a patient with stage 1 testicular cancer, you've got a 99% chance of being cured and cancer-free at the 5-year mark. Because the cure rates are so good, we're really trying to limit any toxicity from treatment. Now, when the pathologists look at the testicle under the microscope, they're going to comment on some features in addition to whether it's a non-seminoma or a seminoma, such as whether there's invasion into the lymphatic and vascular channels, such as whether there's invasion into the rete testis, the size of the tumor, the histology of the tumor. Suffice it to say that among non-seminomas, about 30% of patients, despite having negative CT scans and blood work, will develop a recurrence down the way. Now, importantly, even if they do, they're still 99% curable. Of the seminoma patients, it's about 15% of patients that will have a relapse down the way. And again, they remain highly, highly curable. So generally, the accepted preferred strategy for patients that have access to medical care is to go on what's called a surveillance program. And what that basically means is periodically, somewhere in the kind of every 3 to 6 month range, we're getting CT scans, we're getting blood work, and we're making sure that you're not in that small proportion of patients that are going to have a relapse. And so long as you're not, we continue to monitor. As we get further out from the diagnosis, we can decrease the number of CT scans, the number of lab tests. And after 2 years, there's only about a 5 to 10% chance that you may have a recurrence. We still monitor, but we can decrease the intensity. Moving into the stage 2 setting, where cancer cells may have spread to the lymph node, this is where it becomes a little bit more nuanced. So starting out with non-seminomas, we check the blood work, we look at the size of the masses, we look at what was in the original testicular removal specimen, and the two kind of broad options are chemotherapy, and that can be either 3 cycles of bleomycin, etoposide, and cisplatin, or 4 cycles of etoposide and cisplatin, or surgical removal of those lymph nodes in a procedure called a retroperitoneal lymph node dissection, or RPLND. If the blood work tumor markers are elevated, almost certainly we're going to start out with chemotherapy. For tumors and masses that are a little bit smaller, where there's not multiple tumors, many times we'll start out with RPLND. And the idea is while the chemotherapy is very, very effective in killing the cancer cells, there can be some pretty substantial short and long-term side effects. And the biggest ones that we worry about are early onset heart disease, development of secondary cancers from the chemotherapy. Sometimes you can develop neuropathy, numbness or tingling, and some hearing losses. Again, it's super, super effective, and we want to remember that. But if we can safely avoid those side effects, that of course would be preferable. RPLND, if it's indicated, again, it should really be done with surgeons and at centers that have experience and expertise in this. That is going to be removal of the lymph nodes in the retroperitoneum. And generally, we're not just going to remove the enlarged lymph nodes, but the other ones in the vicinity where testicular cancer tends to spread to confirm that there's no microscopic deposits that we couldn't see on the CT scans. So that operation can be performed either through an incision or it can be performed minimally invasively or robotically using multiple small incisions. And at the end of the day, this is going to be a determination between the surgeon, the patient. There may be some other factors and features that are considered. And if somebody's going to be doing a minimally invasive surgery, again, they should really be experienced in that approach. Here at UC San Diego, we do offer both minimally invasive and open surgery based on the indication. So generally speaking, we're going to remove the lymph nodes in the area where testis cancer tends to spread first. The operation typically takes about 2 to 3 hours. If it's done minimally invasively, you can go home the same day or typically the next day. If it's done open, you may stay in the hospital for 1 or 2 days. And if we can do it minimally invasively, that does improve the overall convalescence or recovery process a bit. But again, it's important that your surgeon is comfortable with the approach. The main side effects that we always spend a little bit of time talking about for RPLND, just like any major operation, there's a risk of bleeding or infection. That's pretty small, even though we do ask for your permission to give you a blood transfusion. The kind of more pertinent long-term complications are uh, one, the development of an inability to ejaculate or anejaculation. Now, the nerves that go to the penis and allow us to ejaculate are actually running right in the retroperitoneum. An experienced surgeon would nearly certainly do a nerve-sparing RPLND. They may do a templated RPLND where they're staying away from some of the nerves that can cause injury to the ability to ejaculate. But generally speaking, for a RPLND that's done for stage 2 non-seminoma germ cell tumor should be a nerve-sparing RPLND, and the ability to ejaculate should be 95% or better. The second thing is when we remove the lymphatic tissue, we take great care using clips, using cautery, using sealants to make sure none of that lymphatic fluid um, accumulates in the abdomen. But nevertheless, in about 1 to 2% of patients, they will have a development of fluid, and that's called chylous ascites. Usually we can manage that by just sticking a needle in, aspirating it, and it dries up automatically. But sometimes some additional procedures could be required. And then finally, with any surgery, there's a small risk of hernia formation. And those are kind of the bigger risks: inability to ejaculate, development of ascites, or hernia formation. Fortunately, they're very, very uncommon, but they can happen, and it's important that they're discussed with the patient. Now, if in the stage 2 setting you receive chemotherapy, then we go on to get CT scans afterwards. If the blood work is normal, if the CT scans have no more spots, then we just typically would monitor you. If there are residual masses that are bigger than about a centimeter, then after chemotherapy, sometimes RPLND is required, and that's called a post-chemotherapy RPLND. It's a little bit more complicated because now that the cancer cells have been killed, there can be some desmoplasia or a little bit of a reactive tissue quality that can make the operation a bit more challenging. And that's a more complicated operation, really, really should be done at a high volume center. If you received RPLND, as long as there's not lots and lots of lymph nodes that were positive, typically we're just going to monitor patients with CT scans and so forth afterwards. Now, moving to the stage 2 seminoma setting, it's actually quite similar to the non-seminomas. We check the blood work, make sure it's negative. If it's small volume, then we can do RPLND and expect a very similar course as a primary RPLND for clinical stage 2 non-seminoma, or we can do chemotherapy. It's the same chemotherapy regimens, or in select cases, we can do radiation. Generally, we don't like to do a lot of radiation because if after the radiation, your tumor cells were to show up in another area requiring chemotherapy, then the risks of some of the bad things like secondary cancers, heart attacks, strokes, that really starts going up quite substantially. But at a high level for clinical stage 2, whether seminoma or non-seminoma, if it's small volume, normal blood work, RPLNDs, generally the preferred strategy. If it's bigger or if the patient prefers, then we can talk about chemotherapy. And then in select patients for seminomas, we do radiation. And then for select patients with non-seminoma, if they got chemotherapy, we may have to do a post-chemotherapy retroperitoneal lymph node dissection. And then in the stage 3 setting, so if cancer cells have spread beyond the retroperitoneum, the first next critical step is going to be chemotherapy. And there's certain factors, including where the cancer started, where all it has spread to, that dictates the chemotherapy regimens, which absolutely should be done at high volume centers of excellence. And suffice it to say, for seminoma after chemotherapy, the vast bulk of the time, we just monitor things. In non-seminomas after chemotherapy, then we get CT scans top to bottom. And if there are residual spots, post-chemotherapy retroperitoneal lymph node dissection is required because there could be some residual cancer cells. There could be a kind of variant of testicular cancer called teratoma that has to be surgically removed, or it could be all dead cancer cells, and we just currently don't have the test to reliably predict that. So you're going to be okay. And I have no doubt that this is a complicated time for you and your loved ones. But I wanted to give you a little bit of a sense of what to expect across the journey of testicular cancer. There's a lot of nuance here. It's really important that you visit with people that manage this disease, understand this disease, and so we can provide the absolute best care to eradicate the cancer and minimize any long-term side effects. Thank you so much for your attention.